Hello and good evening. We'd like you to join us and thank you for listening to our presentation on comorbidities in children with epilepsy. Seizures are only part of the problem. My name is Julianne Palicki, and I'm a clinical pediatric epileptologist as well as clinical researcher with the Northeastern Regional Epilepsy Group. I'm also a clinical professor of pediatrics at Rutgers University Medical Center. The key points that we'd like to make in this webinar are the following. Comorbidities of epilepsy involve neurocognitive, psychiatric, medical, social issues, and they typically predate the epilepsy. If somebody doesn't ask about a patient having these comorbidities, then you won't know about them, but they do exist. And the third is that safety issues and the risk of death must be discussed with patients and caregivers with people with epilepsy. We'll start by just putting in context a case. This is a case about a young girl that I had seen, and I will not be using her name. The question here was, is it the meds, the epilepsy, or a mood disorder, or all three? She was a 13-year-old girl with episodes of eye fluttering. In retrospect, she recalls episodes when the teacher or friends were doing something she doesn't remember. Also in retrospect, she recalls having a jerking episode in the car several months prior that lasted for a few seconds. She didn't lose consciousness, and it was in the setting of sleep deprivation. We performed an EEG. It was consistent with what's called idiopathic genetic epilepsy. She was started on a medicine called ethosuximide, but after just taking one tablet, she complained of dizziness and headache. She felt like she couldn't concentrate. When asking further about the headache, she described it as a constant forehead pain without any nausea. It would make her feel like lying down, although she was able to watch TV and it would not affect her vision. Her father later shared with me that he felt that the diagnosis of epilepsy had worsened her mood, leading her to lie around the house, not participate in her social activities, and complain of a headache. Her past history was unremarkable, and socially, she admits to having difficulty in school, which had gotten worse with the diagnosis. She did not have any alcohol or drug use involved as well. There was a family history of mood disorders, and on examination, there wasn't really anything to speak about, but her affect was somewhat down, and it brightened when her parents left the room. So what would you do with this patient? We're going to return to her later after we hear more about the comorbidities so we can keep her presentation in context. Well, there's many common comorbidities in children with epilepsies. They range from cerebral palsy and cognitive impairments through chromosome abnormalities and psychiatric disorders. In a national profile of childhood epilepsy performed with close to 100,000 children, they showed a much higher prevalence of depression, anxiety, ADHD, conduct problems, and autism, in addition to headache and social issues. We're going to be breaking these down during the talk into different categories to address them. So to break them down, I'd like to think about that there are medical issues and focus on reproductive issues, nutritional problems and focus on bone health. There are multiple neurological issues, including autism, migraine, sleep disorders. But our real focus here is to focus on the psychiatric and cognitive disorders that are unfortunately part and parcel of a patient typically having epilepsy. I also focus on recent research in order to give our webinar some current context in terms of what is the newest findings. A recent article in Epilepsy and Behavior has shown that out of 260 patients with epilepsy, half and half male and female with an average age of 42 years, that the average bone analysis, 52% showed low bone mineral density and 11% had frank osteoporosis. And obviously this was at a fairly young age. This just identifies the idea that many of our patients with epilepsy do have bone demineralization. In addition, the studies showed that patients who had undergone bone density analysis tended to increase their calcium and vitamin D supplementation, but not do other, as they called it, osteoprotective behaviors, such as exercise and diet that could also help their bone strength. Interestingly, bilirubin density was worse in the male epilepsy patients as opposed to female epilepsy patients. And in a vitamin D study of 596 epilepsy patients, overall 45% had vitamin D deficiency. This is associated with some of our medications, anti-epileptic drugs, or AEDs, that tend to be what's called enzyme-inducing, or rev up the liver in order to process some of our metabolism. In these cases, patients tend to have a lower vitamin D if using these medications. Although even in patients without enzyme-inducing AEDs, they also have a 37% of vitamin D deficiency. So where does we stand? Children and adolescents should be treated with vitamin D supplementation and calcium due to the fact that we know that they'll have problems with bone metabolism, bone mineral density loss, and are 2 to 3 times the fracture risk of healthy controls. In addition, vitamin D levels should be routinely checked and supplementation provided. As mentioned, certain of the medications have more in effect than others of the medications, and especially the enzyme inducers. And recent work by Martha Morell has shown that a decrease in estrogen from the central source, in other words, a brain source, may be a more consistent feature even than the low vitamin D levels themselves. Moving on to other health issues, reproductive issues are very much of a concern with patients with epilepsy. And we usually try to initiate these discussions early in the course of treatment in order to avoid misconception. In women, sexual dysfunction in women with epilepsy was reported at 14 to 50%, with most difficulties arousing arousal and libido. In addition, there's a failure rate of some of the oral contraceptives, again increased with the enzyme-inducing anti-epileptic drugs. In addition, there's a risk of polycystic ovary disease, much more in patients taking a valproic acid, and increased even further in the combination of valproic acid and carbamazepine. In terms of pregnancy issues, infertility is 40% more common than the general population. This is probably multifactorial, involves irregular menses, polycystic ovary disorder, increased miscarriage rate, and increased pregnancy-related complications. There's a 30% increased risk of seizures in pregnancy secondary to hormonal changes and changes in patients' drug pharmacokinetics during pregnancy. However, it's not all a dim prognosis. Most women, greater than 90% of pregnant women with epilepsy who do get proper medical treatment, can have healthy outcomes. They need to be warned, however, about a risk of abnormalities born to children with epilepsy, and they can reduce this risk by having a yet increased, especially in folic acid supplementation to decrease some of the potential adverse risks associated with women and epilepsy and pregnancy. A further focus on new information on pregnancy is with one of our medications, valproic acid. More recent research has shown that women who are taking valproic acid did have a higher risk compared to controls, and this was statistically significant, of having children with neurodevelopmental disorders, and the most common was autism. There was no association with women treated with carbamazepine or lamotrigine, so it seemed to be a very drug-specific effect. And we need to warn our patients, who especially are on that medication, prior to them planning a pregnancy. For women with epilepsy, contraceptive counseling is important. Oral contraceptives need to contain a greater amount of estrogen, especially if they're on enzyme-inducing anti-epileptics. Barrier methods should be recommended for breakthrough periods. Polycystic ovary symptoms should be screened for and referred for gynecological management if present. And any woman who's post-menarche years should have an increase in their folic acid to prevent against possible birth defects. And if they're on valproic acid, that should be increased to 4 to 5 milligrams per day. Women should be counseled, again, for calcium and vitamin D supplementation and should consult both a high-risk pregnancy OB as well as their neurologist prior to planning pregnancies. Another medical and neurological issue that epilepsy affects is sleep. And this is an area where there is a recent but still very new focus. It's shown that children and adults with epilepsy have an increase in sleep-related disorders. These include obstructive and central sleep apnea, sleep initiation, and disruption of maintenance. This often causes a difficult cycle in that the problem sleeping then cause sleep deprivation, which can worsen the epilepsy overall. There are many scales to assess whether someone's sleeping well or not. These are readily available to screen in patient populations, but just some easy questions to ask when seeing patients are, do they wake rested? How well do they sleep? Do they snore? Do they sleep through the night? And if there is a problem, is it with falling asleep or maintaining sleep? Because the importance of the sleep hygiene and the control of epilepsy is so important that we refer to sleep specialists if needed. Headaches and migraine are also associated with epilepsy, and this is more common in patients who have epilepsy from a single source as opposed to epilepsy that's generalized. In general, there's no clear association with the localization of the epilepsy, however, and the location of the headache. Most patients will say it comes from the frontal head. There is an increased risk of headache with patients with epilepsy who also have a family history of migraine. And this has been studied genetically in a very large NIH-sponsored epilepsy phenome-genome study where specific genes are being identified with this association. Again, there are very set guidelines and scales to measure whether patients are suffering from headaches, and this should be screened in all of our patients with epilepsy. Moving on now to cognitive deficits. We had in the past always blamed our medications or other issues, the continued seizures, on the cognitive deficits that we see in patients with epilepsy. However, more recent research has shown us that the cognitive deficits are probably the same function as the abnormal circuitry that causes the epilepsy itself. In other words, they predate the epilepsy. Patients who are presenting with first-time seizures were found to already have difficulties with attention, reaction time, and learning. Mild cognitive impairment was identified, and academic problems such as school failure and needing special education was there prior to the first seizure. And this becomes a huge problem, especially for children and adults with epilepsy. In fact, cognitive issues were found to be the strongest risk factor for decreasing someone's health-related quality of life 2 years after the diagnosis. So maintaining this cognitive status is very important in our populations. We even see cognitive features in patients who have what we call benign epilepsies, epilepsies that are common and usually very easy to treat. These include childhood absence epilepsy, where very important NIH studies recently have shown that children have attentional dysfunction, that IQ differentials are reported at the onset of the study, and that school performance is diminished in long longitudinal studies. In juvenile myoclonic epilepsy, it's been described as patients having executive function and expressive language deficits. Frontal lobe dysfunction has been noted in neuropsychological profiles in intention and concentration. And these features are independent of the epilepsy duration, the seizure frequency, and the treatment. In addition, this group of patients, JME, has been followed very long-term, especially by the Campfields in Nova Scotia, and found to have significant psychosocial complications, such as underemployment, social isolation, depression, that further warrants treatment. In another benign epilepsy, benign Rolandic epilepsy, the most common localization-related epilepsy in children, it's thought that approximately 24% of children have some neurocognitive deficits, typically seen as linguistic difficulties on neuropsych testing, reading, and attention. And more research has been done to see if there's a correlation between higher spike frequency and bilaterality with the neuropsych deficits. These deficits, however, can resolve or normalize with the epilepsy syndrome, and adults who have had benign Rolandic epilepsy tend to have a very good course. Now, there's a strong neurocognitive association with our epileptic encephalopathies. These are very difficult to control epilepsy syndromes that are known to have neurocognitive dysfunction. Many of them are genetic, such as Angelman syndrome and some of the epileptic spasm, epilepsy-linked syndromes. In addition, mitochondrial diseases, Dravet syndromes, and Lennox-Gastaut. But even now, we think of temporal lobe epilepsy, which is common in adolescence and becomes one of the most common epilepsies for young adults, as a progressive epilepsy because the continued seizures tend to lead to associated neurocognitive deficits. In terms of autism spectrum disorder, there's much focus on this at this time because the CDC has identified that the diagnosis of autism is significantly increased in recent data. Unfortunately, locally in New Jersey, we have some of the highest incidences rate there is, and it's an interesting fact of these state-by-state variations. Now, many genetic conditions are known to be associated with both epilepsy and autism, such as tuberous sclerosis and Angelman syndrome. We also know from studying populations that about 30% of patients with autism develop epilepsy at some point. When we look at, however, their EEGs, we find that the percentage of patients with autism with abnormal EEGs is actually quite high. Now, there's variable reports in the literature, but this study I highlighted because it is so extensive. It went from 1996 to 2005 and involved over 500 patients. This study showed that over 60% of patients with autism, and these are patients who did not have a genetic condition, brain malformations, prior medications, or clinical seizures, had abnormal EEG epileptiform activity in sleep. There is ongoing research to try to correlate the degree of epileptiform activity and whether there's a significance in the behavioral manifestations. The increased epilepsy risk factors for patients with ASD were summarized in this recent article that came out from Boston Children's Hospital. Intellectual disability and female gender showed in patients to have an increased risk. However, patients also who are syndromic, we talked about those briefly, such as Angelman's and tuberous sclerosis, the severity of the autism itself, patients who have developmental regression, and a family history of epilepsy. For those patients with autism, their risk for developing epilepsy is increased with intellectual disability and particular seizure types. We know, for example, that patients with epileptic spasms are much more likely to go on to develop autism as other seizure types. Moving on to another group of disorders, and unfortunately a very large group of comorbidities for patients with epilepsy, and that is the prevalence of psychiatric disorders. As you can see, that epilepsy increases the risk of patients having depression. And it's a pretty significant number, estimated with huge variance between 11 and 60, but certainly greater than the overall population. Anxiety also increased as well, and these two conditions tend to travel together. Psychosis, on the other hand, mildly increased, certainly above background, with a substantial increase in the diagnosis of ADHD and epilepsy. Again, the psychiatric disorders tend to antedate or go before the epilepsy onset. 45% of children with new onset idiopathic epilepsy had a psychiatric disorder prior to seizure onset. And you can see in this population that anxiety and then ADHD were the most common that were there prior to the diagnosis. And in addition, behavior problems, up to 32%, were seen in children prior to the diagnosis of their epilepsy. Again, bringing to mind the fact that epilepsy is a circuitry disorder of the brain that causes other maladies, such as psychiatric disturbances due to its circuitry nature. In terms of ADHD, children with epilepsy are at substantial risk for ADHD. There's a prevalence of estimated of 30 to 40%, which is several-fold higher than the normal population. Children with epilepsy and ADHD differ from children with ADHD and without epilepsy, as tending to have a higher incidence of the purely inattentive form of the disorder. And in general, the population, ADHD is more common in boys than girls, whereas in children, we see that there's an equal male-to-female ratio. We also see that 38% of epilepsy patients had a provided diagnosis of ADHD when first presenting and giving tests for ADHD. And we'd like to point out that for patients with epilepsy and ADHD, we do recommend the treatment of both disorders. Methylphenidate or Ritalin and all of its derivatives are in general quite safe for pediatric epilepsy patients with comorbid ADHD, as an extremely low percentage of patients who have seizure worsening because of the use of a stimulant. In terms of pretreatment cognitive defects and treatment effects on attention, not all of the effects of attention that we see in patients with epilepsy are pure ADHD. What we saw in a large cohort of patients from the Childhood Absence Epilepsy trial is that there's a high rate of pretreatment attention deficit, that these deficits persist despite seizure freedom, and I think that's important to point out. That regardless of the fact that the seizures go away, the underlying circuitry issues cause these attentional problems. Certain medications can further make that worse. So in that trial, we found more attentional difficulties with people who were then placed on valproic acid versus ethosuximide and lamotrigine. Some of the symptoms were unrecognizable by the parents, and only through cognitive and behavioral assessments was the attentional issues pointed out. Behavioral issues is another common comorbid complaint that patients with epilepsy discuss with us. If you look at the percentage that are available in controls, is usually 7 to 9%. It certainly increased from chronic illness models of 12 to 11%, gives it somewhat of an increase. But the 58 to 56% shows that this increase in behavioral problems in patients, especially with complicated epilepsy, has something very intrinsically to do with their disease. Another study, 224 children with new onset seizures compared to their siblings, showed that there was significantly more behavioral problems in the children above their siblings, and even more so in the children who had recurrent seizures. So in other words, both children with epilepsy were significantly greater behavioral problems than their siblings. But the children who continued to have seizures also continue to have those behavioral problems. So they seem to go hand in hand with the behavior themselves. The major risk factors for having behavioral problems are underlying neurological dysfunction, various seizure variables. There are certain types of seizures, again, that tend to go part and parcel with behavior problems, such as atypical absence and myoclonic seizures, family environment, and side effects of some of the medications. It can worsen the behavior problems in children predisposed to behavior problems to begin with. Children with new onset seizures have a rank order of total behavior problems in terms of, we talked about this, the recurrent seizures greater than a single seizure, greater than a sibling. And it, again, raises that possibility that both are caused by the underlying neurological disorder. Aggression itself is probably an underrated or underreported comorbidity with epilepsy. It's described specifically in patients with juvenile myoclonic epilepsy, seizures that have an origin in the temporal lobes, and some of our epileptic encephalopathies, especially Lennox-Gastaut syndrome. And the patients with Lennox-Gastaut syndrome tend to exhibit more aggression when they're better treated. Children with cognitive impairment seem to be more at risk for aggressional problems. And there are certain medications that seem to precipitate the aggression. Clobazam has been shown to have somewhat of a dose-dependent effect initially, but there's some tolerance with that over time. Also, phenobarbital, levetiracetam, and sometimes lamotrigine have been described in certain patients. Typically, our treatment would be to either lower the dose, decrease or change one of the medications, or use other behavioral modification therapies for treatment. Probably the biggest and most concerning issue for patients with epilepsy is depression. It's the most common affective comorbidity. It's present in 10 to 20% of patients with controlled epilepsy, probably 50 to 60% in uncontrolled epilepsy. It has a significant effect on quality of life and a negative impact on a patient's morbidity and prognosis. Risk factors include a family history of mood disorder, younger age of epilepsy presentation, being on multiple anti-epileptic drugs, having a higher seizure burden, greater than 1 per month, having localization-related epilepsy, and having other psychosocial difficulties to deal with in a patient's life. If we look at the rate or percentage of epilepsy proportion in a study by Kanner et al., we can see that in the general population it was estimated close to 10%. Certainly chronic illness somewhat increases, but you can see that there clearly is a direct neurological component to the increase in epilepsy comorbidity and depression. There's a somewhat increase of manic depressive syndromes in patients with epilepsy, but there really does seem to be a correlation with depression, and prevalence for men and women was identical. This is a theme that you've heard now throughout the webinar, that many of our disorders, even though in the control or general population might be more frequent in women, such as osteoporosis, such as depression, are equal. Similar to ADHD might be more common in boys, but ADHD in epilepsy patients is the same for boys and girls. It's important to point out that the presentation of the depression may be different in patients with epilepsy. There might be intermittent irritability, rapidly changing periods as opposed to the sustained depression, a lack of energy, insomnia, which is often blamed on the medications, anxiety, fearfulness, anhedonia, lack of feeling pleasure. Often the children will go along with the daily events, but just not have that joy and participation. And remember that the irritability might be the strongest factor. There are many notable scales in order to screen for a patient having depression, but it's often under-recognized and undertreated in patients with epilepsy. Several papers have focused on this issue as to why. And the reasons have been found that patients tend to minimize their psychiatric symptoms. The symptomology tends to be somewhat different than patients without epilepsy. But as physicians or medical providers, we don't have the time to ask about what was going on. And sometimes it's considered a normal adaptive response, but it shouldn't be, and we need to be asking for it. This is a PET study showing the difference between patients who are depressed and not depressed, and certainly we don't have the ability to do PET studies on all of our patients for diagnosis, but certain questionnaires can help us as well. What are the risk factors for depression? Age, family history, stress, and social, as we mentioned. Discontinuation of some of our medications that may have been sustaining mood. So some of our medications are quite good at mood stabilizing. As we take a patient off it, they may have a worsening of their depression. Certain of our medications, however, are known to have negative psychotropic properties, and the one in particular one should be cautious about is phenobarbital, and 40% of patients treated with phenobarbital are reported to develop some degree of depression. There's another entity, it's often discussed in epilepsy literature, called forced normalization, where a patient with recent seizure control, either with medications or surgery, can then have a worsening depression as the epilepsy is controlled. In terms of treatment, there is a recommendation for both cognitive behavior therapy as well as medical therapy as necessary. Counseling and medical therapy should be used in conjunction and not to the exclusion of each other as necessary for the patient. There are some antidepressants, especially bupropion and the TCAs, which may lower seizure threshold. SSRIs in general are quite effective and well tolerated. As we mentioned, one needs to also keep on the lookout for anxiety, and generalized anxiety disorder as well as panic disorder may be present in patients as well. Anxiety in the presence of depression in an epilepsy patient increases the risk of suicide, which we're going to discuss as well. This is less studied in children, and we need to be screening for our patients. Some of our medications will activate this anxiety, such as vigabatrin, lamotrigine, or topiramate, or the withdrawal of benzodiazepine, which may have been having some anxiolytic properties. Some of the anti-epileptics, on the other hand, do have anti-anxiolytic properties and can be used in conjunction as well. As mentioned as well, cognitive behavioral therapy is recommended, and this often goes part and parcel with comorbid depression. Suicidality has gotten more focus in our epilepsy patients. It is known to be at 2 times the risk of the general population, and it's felt that 20% of children and adolescents with epilepsy may experience suicidal ideation at some point. A prior psychiatric diagnosis occurs in 90 to 95 patients who commit suicide, so that we need to be screening these patients in advance, having them get proper therapy so they don't lead to this course. And that's why proper screening and therapy is so important. It has the similar risk factors as depression, including childhood onset of epilepsy, but the presence of cognitive impairment actually increases the risk 10 to 25% in patients. The time period at risk is the first 6 months after diagnosis, especially for adolescents, and especially if there's been a relapse of control. Again, phenobarbital is a particular concern, with 47% of patients on phenobarbital describing some kind of suicidal ideation versus a lower amount on a medication of carbamazepine. As many of you know, a lot of our anti-epileptics, all of our anti-epileptics, even those moving forward, have an FDA labeling for the risk of suicidal ideation. And the question is that the epilepsy itself or really the medication? There probably are of the medications that do increase the risk, but it needs to be pointed out that the disease itself increases the risk of suicidal ideation. There are pediatric risk scales, but a series of questions about: do you feel like hurting yourself? Have you ever hurt yourself? Do you feel like hurting yourself now? And how would you do it? Are good, careful screen, and this should be done to the patient individually. And please remember to do a careful skin examination. We do it for neurocutaneous findings, but we should also be looking carefully for evidence of self-harm, which may be the first risk factor. And then as a comorbidity, we have to discuss the fact that our patients could die from epilepsy. This is usually referred to SUDEP, or sudden unexplained death in epilepsy patients. In a recent poll, 61% of patients and caregivers did not know that this was a risk that they faced. But when asked if they did want to be told, only 3% said they didn't want to be told. So there really is a chasm here in how we're educating our patients and caregivers. Risk factors are young adult, especially male, poor adherence to therapy, multiple anti-epileptic drugs, and uncontrolled seizures, especially those that go on to secondary generalization. The rate is about 1 in 1,000 of people with epilepsy, but 1 in 150 if the seizures are uncontrolled. And this statistic is quite striking, but it accounts for 50% of the patient deaths with drug-resistant epilepsy. So half of the patients with drug-resistant epilepsy may die from sudden unexplained death in epilepsy. The Camfields did a very, very detailed study of 2,239 epilepsy patients looking at this risk of mortality in their patients. And they found that most of the excess deaths in the epilepsy patients were not related to seizures. That in complicated epilepsy, the mortality was significantly higher than the general population. And the SUDEP rate was higher than SIDS, which is quite striking when you think of the amount of attention and research that we've provided towards SIDS and the amount that we do not discuss with our patients regarding SUDEP. In uncomplicated epilepsy, seizure-related death was similar or higher than common causes of death, such as accidents, suicide, and homicides. So this is a real risk to our patients that we need to be making them aware of. And on one final note, this chart published by Shinar several years ago just shows that especially for patients with remote symptomatic cause, that this risk of death does continue over time and increases over time as well. And then the final comorbidity to discuss is just overall social functioning. This came from a 2001 U.S. survey of high school students. 20,000 were asked, and they were just asked, various questions about patients with epilepsy. Their responses were quite striking. They felt that 20% felt that epilepsy is a mental illness, and 30% were unsure on that question. 50% were uncertain if people with epilepsy should ever drive cars, marry, or have children. 51% of people felt you die during the actual seizure. 50% were unsure if epilepsy was contagious. Obviously, you'd have to stay away from them if you were. 30% said they would never date someone with epilepsy. And 50% said that you could probably tell if somebody has epilepsy just by looking at them. In a similar and related survey of 271 medical and law students, these should be educated people, if you will, 50% believed that capricious and severe violence was possible or likely during a seizure, which it is not. So it's really not surprising that people with epilepsy, especially adolescents, have problems accepting the diagnosis, accepting what the medical professionals say about it, and have problems being accepted by their peers. So this social discussion is certainly a comorbidity of the disease itself. Well, what should we do with our broody teen? As you remember, we put her on a medication. She was just not taking one pill a day, sitting in the house, not going out with friends, not engaging in her social activity, having a worse time in school, and complaining of headaches. Sounds like a lot of the things that we've discussed in the webinar. We discussed her treatment options. One was to consider a levetiracetam. But there was a concern about already existing mood problems, and levetiracetam can at times increase, especially that irritability factor. What about valproic acid? Well, it's great for epilepsy, for mood disorder and for headache. But as we mentioned, there's concerns in this young woman of reproductive concerns, a risk for weight gain, and the development of polycystic ovary syndrome. We discussed topiramate, very good for headache, some concerns for mood, but it's unfortunately ineffective for the type of seizures she was having, the absence seizures. Another option would be lamotrigine, good for absence, other types of seizures, good for mood. It could exacerbate myoclonus or jerking type seizures and have no effect on headache. And hopefully by now you've gotten the point that now when we choose medications in 2015, we don't just choose it based on the seizure type. We choose it based on the seizure type plus the person plus the potential comorbidities in order to improve the overall quality of life. So you probably can guess we chose lamotrigine, and in the initial titration she improved her absence. She did have some exacerbation of myoclonus, but her headache improved, and she said she was thinking better and clearer. As we increased the medication, she had rare myoclonus. The absence became completely controlled. Her headache, mood improved, mainly because, as her father said, she went away to summer camp with all of her friends. And on follow-up visits, she was more engaged and happy and ready to restart school, where we identified she did need some special resources in order for improvement. So as you can see, treating the patient is very important to consider the treatment not only of their comorbidities, but their social milieu, their educational milieu, and other factors that are going on in their life. As we have said, that patients with epilepsy have high incidence over their age-matched controls in many neurocognitive, psychiatric, medical, and other neurological issues. And it's important to screen patients for these disorders at every appointment. It's important to find out if there's relations with meds, but also to keep in mind that it's a part and parcel form of the disorder, and we need to sort that out as well. Also keeping in mind that continued seizures increases the risk factor of all of them. In order to improve the outpatient encounter, we should screen for the adverse med effects, discuss bone and reproductive health, assess physical fitness activity, review sleep hygiene, screen for mood disorders, screen for educational function, screen for behavioral problems, and assess other family and patient concerns. Now, certainly that seems like a lot, but a lot can be done by questionnaires, prior discussions, and ongoing discussions with the family and the caregiver and the patients as well. Always keep in mind that seizure freedom has the highest impact on quality of life, and it's tied in, though, to proper diagnosis, appropriate treatment, and treatment adherence. In other words, taking the treatment that you've been prescribed. Comorbidity counseling is appropriate probably at every single visit. And reminders of seizure lifestyle factors, what safety factors to address regarding driving, swimming with supervision, avoidance of unprotected heights, to avoid seizure-provoking lifestyle factors, sleep deprivation, alcohol and drug abuse in particular, and really to have a proactive, healthy lifestyle which improves seizure control, such as regular sleep, hydration, meals, exercise, and finding a positive stress relief. I'd like to thank you very much for your attention as we discussed the various comorbidities in children with epilepsy. I'm sure that you've realized that seizures are now only part of the problem, but they're an intrinsic part of identifying the comorbidities to really treating the overall person and making allowing them rather to function the best as they can in their environment and to really achieve quality of life. Again, I'm Julianne Palicki. I'm a pediatric epileptologist and clinical researcher with the Northeastern Region Epilepsy Group and a clinical professor at Rutgers. And we're happy to take any of your questions. Please email them to the webinar organizer, and we're happy to answer them. Thank you again very much.